Esophageal cancer is one of the most aggressive gastrointestinal cancers, largely because it often presents late. Today, we're going to cover your risk factors, who's at risk, how patients present, how do we diagnose and stage it, and treatment per NCCN guidelines. We'll also talk about surgical options and postoperative nutrition, complications, and what long-term surveillance looks like. There are two main types of esophageal cancer. Adenocarcinoma, which occurs in the distal esophagus and is most common in Western countries. It's actually associated strongly with gastroesophageal reflux disease in Barrett's esophagus. Squamous cell carcinoma, on the other hand, occurs in the mid or proximal esophagus and is more common worldwide. Risk factors include tobacco, alcohol, obesity, achalasia, caustic ingestion, and prior radiation. Overall incidence is higher in men, typically presenting in the 6th or 7th decade.
Almost 98% of people watching this aren't subscribed. If you're a medical student or resident who wants to think more clearly, prepare more efficiently, and perform better under pressure, this channel is built for you. Click the like and subscribe button and let's keep on going.
So how does this present? The most classic symptom is progressive dysphagia, starting with solids, then liquids. Other symptoms include unintentional weight loss, odynophagia or painful swallowing, chest pain, hoarseness when there is advanced disease and invasion of other structures, chronic cough, and iron deficiency anemia. By the time symptoms appear, the disease is often locally advanced. The initial evaluation starts with an upper endoscopy with biopsy for tissue diagnosis. Once cancer is confirmed, staging includes a CT chest, abdomen, and pelvis with IV contrast, and this is looking for metastatic disease. A PET-CT to assess occult metastasis is also considered, and endoscopic ultrasound to evaluate for T and N staging. It looks at tumor depth, and if there are going to be lymph nodes which are enlarged. This determines whether the patient is a surgical candidate. The staging follows the TNM staging. T for tumor depth of invasion, N for regional lymph node involvement, and M for distant metastasis. The treatment depends on stage and patient fitness. Very early disease may be managed with endoscopic resection. Locally advanced disease typically receives neoadjuvant chemoradiation followed by surgery. Metastatic disease is treated with systemic therapy and palliation, and sometimes that may include stenting. Multidisciplinary tumor boards are critical in decision making. So how is this surgery performed? The goal of surgery is complete tumor resection with negative margins and a lymphadenectomy. Common operation includes Ivor-Lewis esophagectomy, which goes through the abdomen and the chest with an anastomosis in the chest. A transhiatal esophagectomy that goes through your abdomen and into your mediastinum, and a counter incision to the neck that then resects and does a neck anastomosis. The stomach is typically used as a conduit and pulled up to replace the esophagus. Minimally invasive and robotic approaches are increasingly becoming more common. Postoperatively, nutrition is a major part of recovery. Patients often start with jejunal tube feeds and gradually transition to oral intake. Patients often start with small frequent meals. They avoid lying flat after eating because of the reflux that occurs. Dumping syndrome and early satiety are common early on. With these surgeries comes potential risk of complications, and they can actually be devastating. When an anastomotic leak occurs, it depends on where the anastomosis is. So if it is actually in the thorax in a Ivor-Lewis, that can cause mediastinitis and cause arrhythmias and can become deadly. For those in the neck, they can develop an abscess, also may extend into your mediastinum if it leaks down. Pulmonary complications, recurrent laryngeal nerve injury, delayed gastric emptying, and strictures. Early recognition and multidisciplinary care are essential. For surveillance for recurrence, post-treatment surveillance includes routine history and physical, periodic imaging, which is yearly, endoscopy when indicated depending on your staging and your risk. The recurrence risk is highest in the first 2 to 3 years and may be local or metastatic. Patients also require long-term nutritional monitoring and quality of life support. Esophageal cancer is aggressive, but early recognition, appropriate staging, and multimodal treatment can significantly improve outcomes. Understanding the disease from presentation to surveillance is essential for anyone caring for these patients. If you guys liked the video, please type in your comments down the chat, click the like and subscribe button, and check out our other videos, and I'll see you guys next time.